The FDA announced that they were concerned about an excess mortality signal with paclitaxel devices used in the periphery for typically SFA intervention. And I think this announcement is different than prior announcements. What's been happening is there was a meta-analysis that showed there was increased mortality with these devices. We really couldn't figure out why that was. There was no causative mechanism, but yet the mortality seemed to be higher. But with this FDA review and this announcement that physicians ought to consider using alternatives, plus the fact that we live in the United States with our legal system, I personally don't see a reasonable way that someone like myself could proceed and use these devices as first line. What we had instituted before this was the discussion of informed consent, so talking to patients and explaining to them what was going on and then going forward. But after this announcement, I don't know how you get true informed consent for something that has a mortality signal. Do I believe that I know why this mortality signal exists? Not at all. But at the same time, if something bad were to happen to a patient, then as a physician, I would feel terrible about that, not knowing whether that was associated with something that I did. And so just from that standpoint, absent even the liability issues, I think it'd be hard to use these agents as first line going forward.
The problem is that, we really have to understand that these drug-coated balloons have been incredibly useful in critical limb ischemia. And in these patients that this was for SFA disease from the data that was collected. And so if you ration it to those patients, you're really looking at some major issues. So what they're saying is, they're saying use alternative treatments until we figure this out. They see a signal, they want us to figure it out. So maybe it is best to look at that and hope for the best medical management, which I think we don't do a very good job anyway in our patients with PVD. I mean, I think we have a lot of good data for antiplatelet and direct thrombin inhibitors to help with the COMPASS study, but very rarely do we see patients on these treatments. So I think we can do better medical management, but still I would say that drug-coated balloons, specifically the paclitaxel-eluting balloons, have been very helpful in helping these patients with really good results as far as patencies goes. But having said that, the caveat, and I think what we learn from this as we look at this, is that when we are performing studies in the peripheral vasculature, it should be with the same level of scrutiny as any other way that we are doing this, so that we're not coming back and we're not at this stage of looking back at the data with a lot of crossovers, lots of follow-up, and not know what to do with the data. And that's where we are right now.
Many times when we do trials, we obviously have endpoints of interest. And those endpoints we characterize very well. And then we have trials where we have what I call unexpected signals. And the whole issue then becomes, how do we deal with this? There's been studies on this with pharmacological therapies because those are larger studies. There's adverse event reporting that goes along with those trials. And sometimes there's been unexpected signals. In fact, in one of the studies that I was partially involved with many years ago, there was unexpected signal on cancer. Everybody got very upset. But when the data set was cleaned up, the signal wasn't there. It could be explained by other issues. So I think in this recent sort of question, I think it goes back to the science. How much do we actually really know? And how clear is the signal? And how sure are we that everybody is accounted for? Because if it's not the primary endpoint of the trial, then we need to be absolutely sure we understand that. That becomes a very important issue.
I think there is a way to look at the studies that were done and try to get as much follow-up as possible on the patients who were actually already enrolled and were lost to follow-up, finding death indices in those lost to follow-up patients, etc. Understand the crossover, because in the meta-analysis, this was not a patient-based meta-analysis, so we do need a patient-based as treated meta-analysis. If we're going to see that something is toxic, it should be a ITT, but as treated if they received the drug-coated balloon. What happened when they crossed over? We need to understand those patients as well. And And with that kind of data, we'll have a better understanding. And if then again there is a possibility of a signal or uncertainty, I think doing a prospective study where there's excellent surveillance and then a long-term follow-up, the way we do in coronary stents and coronary studies, should be done exactly in the same way.